So radial nerve. Radial nerve is going to start posterior cord of the brachial plexus, right? From posterior cord is going to give off the axillary nerve and the radial nerve. Axillary nerve goes to control the deltoid, right? The deltoid is the major, what? It does that. What is that? Shoulder abduction, right? Okay. Radial nerve, however, is going to dive deep to the triceps. It's going to control the triceps. What do the triceps do? Extension of the forearm, right, at the elbow. Can it produce extension at the shoulder? Long head can provide minimal. Yeah, long head can provide some assistance in the extension of the shoulder, right? Because it crosses the shoulder by attaching to the scapula at the infraglenoid tubercle. Okay. Now, once the radial nerve passes by the triceps, right? It's actually what it's going to do. So it's sitting back here, right? And it's traveling through a groove on the humerus, known as the radial groove, right? Might also be called the musculospiral groove. Same thing, right? But it's traveling from medial out laterally. Then what it does is that it actually ends up traveling anterior to this lateral epicondyle. Okay? It travels anterior to that lateral epicondyle. For a brief period, for a brief moment, you can actually find the radial nerve. You should actually try this in lab. You could find the radial nerve lying sandwiched between the brachialis and the brachioradialis as it travels anterior to the lateral condyle, right? Then it's going to dive deep to the extensor carpi radialis longus and brevis, and at that point, it's going to bifurcate, okay? It's going to bifurcate into a deep radial nerve and a superficial radial nerve. Superficial already tells you that its job is superficial, right? So is it going to be a motor nerve or a cutaneous nerve? Cutaneous nerve to what area? Dorsum of the hand, right? Which means if we're back at that situation with Saturday night palsy, right? I got a compression up here that's knocking out my radial nerve. Not only will I have wrist drop, but what other symptom can I have? Numbness in a small area right over this this area right here over the first web space. Okay? Now, why just this small area? In the textbooks, they show you almost this whole freaking thing, half of the fourth digit being covered by radial nerve territory. So why is it just this? There's overlay from other cutaneous nerves in the area, from ulnar nerve, from median nerve, right? There's overlay. So really there's only going to be a tiny spot over here that would actually be clinically significant if that's the issue. You're trying to bridge the gap between human concept and nature. It's not, doesn't fit 100%, right? So superficial and deep radial nerve. Okay, where would you find the superficial radial nerve on a cadaver in the forearm? Like, where can I look for it? Okay, it's going to be in the fascia because it's cutaneous, right? But where? In relation to what muscles would I find it? So if you look for your brachioradialis and you look directly deep to the brachioradialis, right underneath it, you'll find a superficial radial nerve traveling. Okay? Deep to the brachioradialis. Okay, you'll find the superficial radial nerve traveling, and then eventually what it's going to do is that it's going to travel through this thing right here, which is called the anatomic snuff box. Okay? So you'll find it traveling deep to the brachioradialis, it'll come out from underneath it and go right over the snuff box. Okay, that's your superficial radial nerve. What about the deep radial nerve? The deep radial nerve, right, is not going to travel superficially. It's going to go deeper, right? And it's actually going to pierce through a muscle that attaches to the ulna but wraps around the radius. The supinator, right? And why does it wrap around the radius? What does it have to do? It has to supinate, right? So it has to pull that radius from the pronator position and rotate it around into supination, okay? Now, that deep radial nerve is going to pierce through that supinator, okay? And then once it comes out on the other side, it is now called the posterior interosseous nerve, okay? Now it's called the posterior interosseous nerve. It's deep, so it's going to be deep enough to run along or over the interosseous membrane, right? But it's in the posterior compartment, as opposed to the anterior interosseous nerve, which comes from the median nerve. Posterior comes from the radial nerve.
Wait, so it comes from two different nerves?
Oh yeah.
Wait,
Anterior interosseous nerve comes from the median nerve, right? Anterior interosseous. Posterior interosseous nerve comes from the radial nerve.
Dude, that makes so much sense.
What do you think?
In lab, I was trying so hard to find where the posterior interosseous was, like a link between the two.
Next time I'm there, I'll show you.
Okay.
So that's the situation there. The posterior interosseous nerve will then continue onward to control almost every muscle in the extensor compartment. Okay, besides the carpi radialis longus, carpi radialis brevis, the supinator, the brachial radialis, but everything else is under control of the posterior interosseous nerve.
Is that just like the deep extensors?
Yeah.
Okay.
So, including extensor digitorum. Okay, so it would be the extensor pollicis longus, abductor pollicis longus, extensor pollicis brevis, extensor indicis, extensor digiti minimi, all under control of the posterior interosseous nerve. Okay, now, let's say for example somebody has wrist drop. They don't have a history of getting drunk and passing out on their shoulder. So what's another possible issue that's going on?
Mid-humeral fracture?
Crutches?
Crutches.
Crutches. Okay, crutches. All right, let's say the person wasn't using crutches.
Mid-humeral fracture?
Mid-humeral fracture. Okay, why mid-humeral fracture? How would that?
The radial nerve is closest.
Remember I said it's going through the radial groove, which is on the shaft of the humerus. So if you have a humeral shaft fracture, you can injure the radial nerve. Okay, what if there's no history of fracture?
Gunshot wound.
Gunshot wound, okay, yeah. What if there's no gunshot wound? Idiopathic neuropathy, yeah, let's just call it that, right? Go home. Let's say you ask the guy what he does for a living, he tells you he's a handyman.
Constantly turning the wrist. You're gonna stress the fucking what's it called? Yeah, that constant tension is gonna cause tendonitis.
So what are you doing right there? What motion are you doing? What motion? He's supinating, right? And whenever you're tightening screws, right? You're supinating, so you're actually exerting a considerable amount of force.
Finger drop and Yersime's elbow can both cause radial movements.
Yes. Okay. So with the supinator, in that instance, let's say you overwork the supinator, right? And it gets big and swollen and tense and inflamed. You can compress the deep radial nerve as it travels through it, and then you can have some symptoms of wrist drop or radial nerve palsy in that situation. Golfer's elbow. So what's golfer's elbow?
It's an inflammation called flexor carpi radialis.
Flexor carpi
As
radialis?
well as the pronator teres.
Flexor carpi radialis and pronator teres. So is that going to affect the radial nerve or?
I mean, I was asking because it's in a general area, so could inflammation of these tendons progressively.
So lateral epicondyle, which is, I think that's tennis elbow, that would be more likely to affect the radial nerve.
But that's the extensive.
Yeah, right? Okay, but the golfer's elbow would be most likely to affect the median nerve, if it does at all. Okay, if it does at all, which I don't know if it would. Okay? All right. What else?
Talk about forehand and how that's.
Yeah, I was just gonna talk. Just gonna go there. So, what is this thing called?
The hand of benediction.
Hand of benediction, right? If I was a pope once upon a time, I would bless you like this, right?
You asked
Yeah.
me to make a fist.
That's the point I want to get to, right? They're not gonna walk in and say hi, right? You're gonna ask them to make a fist for you. You're gonna ask them to make a fist for you, okay? And when they try to make a fist for you, right? I can go ahead like this, but I am having difficulty flexing digits 2 and 3. Why?
They've lost the lumbar bills as well as the flexor digitorum profundus for both of those fingers, so they
Okay.
can't come down. And they've lost everything that they are ending, so there's paralysis and adduction of them.
So median. Yeah, you read it. So hand of benediction. You try to make that fist, right? I can't flex these two, which means flexor digitorum superficialis, right, and flexor digitorum profundus are not functioning properly, right? Why is it though, however, that I can flex digits 4 and 5? Profundus, right, is innervated dually by ulnar nerve on the ulnar side and median nerve on the median side. So this side can still work with the profundus. How about the superficialis? Oh, right? So that's why I can't make a complete fist with those, but I could get somewhere. Okay? Good.
And what's like the name of that one?
That's the hand of benediction. So that would be a median nerve palsy.
Can you explain the ulnar paradox?
Ulnar paradox.
Yeah, so
I need you to explain it to me.
it's like they said that when there's a distal ulnar nerve lesion, they'll come in with the ulnar claw naturally, right? But they say that the more proximal ulnar nerve lesions may present with asymptomatic hands, which is strange because you'd assume more prominent effects if more proximal. It was in the first aid.
Ulnar nerve paradox. I feel like I've heard something about that before. I don't know if I studied it well enough to talk about it. I'll get back to you about that. Yeah.
Can you repeat for us what nerve innervates profundus? Is a
Median and ulnar
median and ulnar
Yeah.
versus superficialis
is all median.
all median. And so in the Benedict, what's it called?
Hand of benediction.
Okay, the median nerve is like not.
Correct. The
Okay.
median nerve is the one who has the issue. Okay?
Can you tell
Now-
me about Erb's palsy and Klumpke palsy?
Erb's palsy and Klumpke's palsy. Okay. What does Erb's palsy look like? Okay. Erb's palsy is like this. So how is my shoulder rotated right now? Okay. So is my shoulder rotated so if my shoulder is rotated internally, there's two questions I need to ask myself now, right? One question is going to be, is it that my internal rotators are overly active for whatever reason? Or is it that my external rotators are deficient? My external rotators are deficient, okay? What are my external rotators of the shoulder? Teres minor, teres major.
Teres major is internal.
Teres major is internal, yeah. Teres minor, infraspinatus. Supra is more so initiating abduction. The what?
The posterior deltoid.
Posterior deltoid also, right? Teres minor, infraspinatus do external rotation. Okay, they're back here. They're running posterior to the shoulder joint, right? They're gonna do external rotation, right? What nerves control the infraspinatus and the teres minor? Suprascapular nerve, right, is for the infraspinatus, and then teres minor is axillary nerve. Okay, fine. All right, we have that. What else is the problem with the waiters too?
You lose the musculocutaneous.
You lose the musculocutaneous nerve. Okay, you have a flexed wrist, right, and
You pretty much lose the entire radial nerve.
okay. So, what is it that you can't do?
Extend.
You can't extend your wrist. Okay, so you're losing radial nerve as well. All right.
You can't flex your arm.
You can't flex your arm, so you're losing musculocutaneous nerve as well.
You can't pronate your arm.
You can't pronate your arm, so that's also median nerve as well. Okay. And what is the usual injury, the mechanism of injury that you have that causes this waiter's tip?
Trauma during birth.
Trauma during birth is one. I say gunshot wound. Okay, so this is the whole point. This is bringing it back to the brachial plexus, right? Bringing it back to the brachial plexus and looking at the trunks that we're dealing with, right? So when we were looking at the brachial plexus, we're dealing with which roots? C5 to T1, okay? C5, C6, C7, C8, T1, right? Now, most of the terminal branches, I'm gonna have to draw the brachial
Yeah,
plexus.
please.
I was trying to avoid that.
Wait, let's have someone else draw that. I ain't doing it, but I figured someone else would want to. Yeah, why not?
I've never seen it like that. I'm trying to think like what happens first. Upper trunk. Oh, it goes downward.
If they pull coming out of that,
Sometimes like turn the neck too, that's the shoulders get delivered at the widest parts, you have to give it care.
All right, so let's say so a lot you could I like this little mnemonic device that a senior student taught me when I was first year med student. C5, C6 pickup sticks. C7, C8 lay them straight. All right. So lay them straight. So what is that telling you? C5, C6 is flexion of the elbow. What nerve is that? Musculocutaneous nerve. C7, C8 lay them straight. That's extension of the elbow. What nerve is that? Radial. Okay. So that tells you that C7, C8 are mostly contribute a lot to the radial nerve, right? And we can see by the construction of the brachial plexus how this would happen. Because remember that, let's say we follow a nerve axon from C8. It would go here, it could go this way, but it could also go this way and then eventually end up at the radial nerve. You guys see how that works? Right? If I'm talking about an axon starting at C5, right, I can easily go here, boom, definitely go into the musculocutaneous. I can go here, axillary for sure, right? It also contributes a bit to the radial nerve, but most of the ones of the radial nerve are going to be from C7 and C8. Whereas C5 and C6, most of those axons are going up to the musculocutaneous. Okay? So that's what that's telling you. All right? So again, we're having an injury, for example, if we're landing off a horse and we get an excessive force that's essentially separating my neck from my shoulder, right? What's that going to do to this brachial plexus? Where's most of the tension going to be exerted? On the upper part of it. On the upper part of it, right? So now imagine that you get that excessive force and you get a tear right here at the superior trunk. Right? What does that mean? That means C5 and C6 are done. Okay? Which means musculocutaneous nerve is done. Okay? And let's say it's even more excessive than that and also takes off your middle trunk, right? That causes even more of a problem. Now we're talking radial nerve problems, axillary nerve problems. Median nerve is also going to get affected severely. C8 and T1 is mostly just ulnar. Okay, so ulnar for the most part is going to be fine, right? So the whole presentation that they give you about, the waiter's tip and everything like that, yeah. You know what I mean? That's the textbook representation of what's going to happen. But in real life, they may not present that way. Most likely, they're not going to present that way. Right? Most likely, it's going to be superior trunk lesion and then maybe some weakness with the flexion of the elbow. Okay? And maybe slight internal rotation. But why the internal rotation? Remember, we said suprascapular nerve innervates the infraspinatus. Suprascapular nerve comes off where? Superior trunk. Superior trunk. Right? So let's say this lesion was right before the suprascapular nerve came off. Suprascapular nerve is going to be affected. There's going to be a natural tone to having it internally rotated. Okay? That's where that comes from. That's where that comes from. Now let's think about the opposite situation. Right? The opposite situation. Let's say you're falling off a tree, you grab onto a tree branch, you have an excessive force now going this way. Right? Now it's the lower trunks that are going to be in danger, right? Your lower trunks are going to be in danger. So let's say now, for example, the lower trunk is severed, right? Who's going to suffer the most? Ulnar nerve is going to suffer the most from that, okay? Ulnar nerve is going to suffer the most from that, and what's the textbook presentation of that?
The claw hand, because
Yeah, the claw hand.
the fundus is still innervated by the median nerve, but then the rest of the
Okay.
No, because superficialis is still fully working, right? Because it's medial. But it's the profundus. A little bit, yeah. But it's the profundus that's the big one, isn't it? So what would
The lumbar goes knocked out.
lumbricals and interossei. Interossei also do this. Interossei also do this. Okay? So interossei also do that. So essentially, if I'm asking somebody to do this, what's going to happen is that, remember what I told you about making a fist? You're going to contract extensors and flexors at the same time to stabilize the wrist in a neutral position. If I ask you to make a fist and my extensors contract, because that's just what they do when you make a fist, what's going to happen at my metacarpophalangeal joints? They're going to extend. But I don't have the same power of flexion, right? Because half of my profundus is gone. That's one thing, right? But in addition to that, my interossei, my lumbricals are gone as well. Those are the ones that are going to be producing the flexion that I need at my MCP to balance out what the extensor digitorum is doing. Does that make sense?
Yeah.
Okay? So that's where this ulnar claw actually develops from. It's an imbalance of forces across the wrist and the MCP and the IP and DIP, stuff like that. Okay?